So hello everyone. Today we are going to talk about the prostate biopsy, a very important topic to be understood in the present time where there is a lot of advancements in this field. So we'll start by understanding the basics of the prostate ultrasound, the transrectal ultrasound. So when we talk about the transrectal ultrasound anatomy of the prostate, this is a very wonderful schematic representation by Dunstan Abraham in his review, where we can see that in the axial view, what we have to understand is the color differences which we can see here is basically the ecogenic difference in the ultrasound. So we can see that the peripheral zone as here is hyperechoic compared to the rest of the prostate. The transition zone is the most hypoechoic area of the prostate compared to the rest of the prostate. So the peripheral zone is hyperechoic, the transition zone is hypoechoic, and talking about the central zone, it's very difficult to differentiate a central zone from the peripheral zone and transition zone of the prostate. Whenever we get a transrectal ultrasound, this is the basic axial anatomy. The urethra, as we can see, lies in the center. Sometimes in this view, we can also get to see some calcifications between the peripheral zone and the transition zone. Here, these calcifications might represent the corpora myelitis, which is common in the elderly people. Similar representation in the sagittal view, which is more important for us to understand the sagittal anatomy because it is the view where in which we perform the prostate biopsy. So this is a similar representation of the sagittal view where we have to understand that this is the peripheral zone and this is the central zone and this is the transition zone. So this whole zonal anatomy has to be very clear whenever we talk about the ultrasound anatomy of the prostate. This is the ultrasound anatomy in the normal people. Now, how normally is the normal anatomy seen? If you look at this article, the normal anatomy is not that normally seen. So out of 125 normal people who underwent the transrectal ultrasound, it was found that only 19 of them had a normal anatomy. So the normal anatomy is not that normally seen, especially in older men. So in men more than 40 years, only 4 out of 74 men or actually had a normal prostate anatomy. Some had cysts, some had hypoechoic area, some had hyperechoic area, some had calcification. So these are very common abnormalities which might be seen in transrectal ultrasound. So normal anatomy is not that normal. We have to understand this. When we talk about the detection of suspicious lesions in the transrectal ultrasound, we have to compare it with the peripheral zone. The peripheral zone is the landmark. So how does a suspicious lesion in a transrectal ultrasound appear to be? Now, if there is a lesion which is hypoechoic compared to the peripheral zone of the prostate, it is likely to be a malignancy, like in 17 to 57% of the cases. But not in every hypoechoic lesion is a cancer. 39% of the cases can be isoechoic and 1% of malignancy can be hyperechoic. So this is very important for us to understand. And even the hypoechoic lesion, apart from cancer, it might be because of the granulomatous prostatitis, it might be because of the infarct or lymphoma. So all this might appear as hypoechogenicities in the ultrasound. Let's move on. How did the prostate biopsy evolve? First ever prostate biopsy that was performed was a open perineal biopsy, which was performed in 1926 by Young. And the first ever transrectal biopsy that was performed was a transrectal finger guided biopsy in 1937. Then gradually both the transrectal and transperineal biopsies, they simultaneously evolved in the form of needle biopsies until we reached 1970s, where the first clinically applicable use of transrectal ultrasound came into existence. And then the more use of transrectal ultrasound guided biopsies became predominant. This is a brief timeline. Until 1970s, when the first clinically useful transrectal ultrasound came into existence, and then more of the transrectal ultrasound guided biopsies came into clinical use. These are the different probes which are available for a transrectal biopsy. We'll quickly discuss the transrectal biopsy and then we'll talk about the transperineal biopsies. There are the end firing probes and side firing probes. Now we also have combined probes. The end firing probe, as we can see, has the transducer at the end of the probe, and in the side firing probe there are two types of transducers. One is a transverse, other is a longitudinal transducer. And the biplanar probe, we have both the transverse and the longitudinal. There are triplanar probes available, where apart from the biplanar probe we have a combination of end firing plus side firing. That is, we have both the biplanar and the end firing probe. How do we manipulate the probe to get the imaging? If we are using an end firing probe, this is a very important for us to understand. In an end firing probe, to get an axial view, we insert the probe inside the rectum, then we rock it up and down through the base of the prostate to the apex, and the end firing probe will get actual images of the gland. Like end firing probe, we have to get the sagittal views. We rotate it from side to side to get the sagittal views. Similarly, for a side firing probe, if we have to get a transverse view or axial view, we withdraw it gradually from the base to the apex. We get the transverse views. In case we want a sagittal view with a side firing probe, we have to rotate it sidewards to get this sagittal view. So these are very important to understand how do we manipulate the transrectal probes. Now we will talk about the prostate biopsy. What are the indications of getting a prostate biopsy done? So if there is a PSA based screening in asymptomatic men with high risk, in those patients we get the prostate biopsy done. Or in case of a suspected CA prostate, as in a suspicious DRE finding or symptomatic patient locally or metastatic symptoms, or if there is CA prostate which detected on the TURP for a presumed BPE case, then in that case, we get a prostate biopsy done. Apart from this, we also get a prostate biopsy done depending on the PSA level. So if the percentage of the free PSA, we get it done if the PSA is between 4 to 10 and the percentage of the free PSA is more than 25%, there is no need for biopsy because there is only 8% chance that is going to be a malignancy. And if the percentage of free PSA is less than 10% of the total, then in that case, there is 56% chance that the patient is going to have a cancer. So in that case, we get a biopsy done. So PSA density, yes, we get it done in 4 to 10 PSA. If the PSA density of more than 0.15, it's more likely to be a malignancy, and we get the prostate biopsy done. So what are the indications for a repeat prostate biopsy? Suppose the first biopsy comes out to be negative. What are the indications when we get a second biopsy if the first biopsy does not detect a cancer? So what is the possibility that a repeat biopsy will detect a cancer? So in that case, around 10 to 40% of the patients can have a repeat prostate biopsy suggestive of a cancer if the first biopsy is benign. But there are certain indications you don't do a repeat biopsy in all the patients. We get a repeat biopsy done if there is a persistently elevated PSA or there is a rising PSA which is more than zero point 0.4 or 0.75 nanogram per DL per year. If there is an atypical acinar proliferation, there is a 40% risk it's going to be a malignancy. And there is an extensive PIN, in that case 20 to 30% risk of malignancy. It's not an isolated HDPIN, it's extensive PIN should be there because in that case there is 20 to 30% chance of being a cancer. Now, if there is an MPMRI done, and it's pirates 3 or more, that is likely to be a malignancy. In that case, we get a biopsy done. And if there is a differentiate between the local recurrence for the systemic recurrence in a patient with a PSA recurrence after local focal therapy, in those cases, we get a repeat biopsy. Sometimes positive urinary markers like PCA3 or tissue markers can even suggest a possibility of a prostate cancer. In those cases, also we get a repeat biopsy. So all these indications are recommended by AUA. And this we have to talk about the last thing about the PCA3 and the confirm MDX. We'll talk about them now. This is what the FDA approves. The FDA has approved the Progensa and the PHI. These two are approved by the FDA in patients who had a prior negative biopsy. Now, this Progensa and PHI, they are approved by the FDA, but they are not cost effective. They are very uncertain. At the same time, this is what the EAU recommends. Now, these are all the additional investigation that we can get in patients with a previous negative biopsy. But let's talk about this confirm MDX slightly. This confirm MDX, we get tissue biopsy from the benign prostatic biopsy. We take benign prostatic biopsy from there. And what is the purpose? It says the concept being that the benign prostatic tissue, which is in the vicinity of the malignant tissue, they also have some epigenetic alterations. And these epigenetic alterations are picked up by this confirm MDX test. It's not a biopsy of the malignant tissue we are taking. It's a benign tissue which indicates that there might be a malignancy in the vicinity. So this is a very advanced test, but it's not yet FDA approved. We have to have some idea about this test. And if we move further, this look at the EIU guidelines regarding the asymptomatic men who have a PSA of 2 to 10 and a normal DRE finding, what to do in these patients. PSA is elevated slightly and the DRE is normal and the patient is not having any symptoms. So these are screen detected patients. What are the indications for biopsy in them? So if we get the risk calculators and calculate the risk, and in them we can get an MPMRI done, MRI of the prostate, and additional markers as we have discussed in the previous slide. We can get some additional markers done also. Now, what are the risk calculators? We have to talk about these two risk calculator. One is the PCP trial risk calculator, and the other is the ERSPC risk calculator. Now, if you look at this risk calculators, you just fill the parameters and the calculator is going to give you a risk. And if the patient is under a significant risk, we will biopsy the patient, otherwise not. In the ERSPC risk group, we can see that there are two calculators, 1 and 2 calculators. The one is not using the PSA and second is using the PSA. And there has been studies comparing the efficacy of the two calculators, and this is a very beautiful publication in the BJU journal. And this says that the performance of the ERSPC risk calculator has been found to be superior to the PCPD risk calculator in asymptomatic men with an elevated PSA and a normal DRE. So when we are going to take a biopsy, so it's better to put the patient in an ERSPC risk calculator, and that also we discussed there are two calculators. It's always better to put the patient in a PSA based calculator. So PSA based calculator is superior compared to the non-PSA based calculator, and ERSPC risk calculator is definitely better than a PCPD risk calculator according to this BJU study. Now, let us move ahead to the prostate biopsy techniques. How do we perform a transrectal prostate biopsy? Now, see, first we prepare the patient after a proper consent. These are all the AU and EAU guidelines which we have to follow when we take the patient for a prostate biopsy, and making sure that any anticoagulants should be stopped 7 to 10 days before the procedure. And this novel anticoagulants, they need not to be stopped in every patient before 7 to 10 days. We can stop them just 2 to 5 days before the procedure. If the patient is on high risk of embolism, in those patients, we can bridge them with unfractionated heparin. So this is very important. Now, one most important thing regarding the patient preparation is the antibiotics, which is most of the time into discussion. So we'll talk about the very few important points about the antibiotic prophylaxis. We have to give prophylaxis to all the patients irrespective of whether the patient has risk for infection or not. So this is a golden statement that all the patients will require antibiotic prophylaxis irrespective of the risk, and it doesn't matter whether you give 1 day, 2 days, 10 days, 7 days. So it's not recommended. There are studies comparing the number of days, and nothing has been found to be superior over the other. So in countries where fluoroquinolones is allowed as an antibiotic prophylaxis, the EAU guidelines clearly mention that at least 24 hours of antibiotic prophylaxis has to be given. It's not that less than 24 hours, it's at least one 24-hour prophylaxis has to be given. But there is increasing fluoroquinolone resistance in the European countries, in the Asian countries. So keeping that in mind, the guidelines have now started focusing on the rectal swab culture guided biopsy. But getting anaerobe culture in all the patients is not cost effective. Some studies have started performing the swab culture based antibiotic prophylaxis only in high risk patients. They have found it more applicable and more cost effective compared to all the patients. So this is important. Now, this has come into the guidelines very beautifully. The EAU guidelines 2022 mentions about the antibiotics for a transrectal and antibiotic for a transperineal biopsy. So we have to be very clear about it. For a transrectal biopsy, we must go for a targeted prophylaxis based on the rectal swab, or we have options like augmented prophylaxis, like 2 or more different class of antibiotics, or we can go for alternative antibiotics like fosfomycin even. So these are the antibiotic recommendations for a transrectal biopsy. For a transrectal biopsy, we should also keep in mind this very important, the point number 3 that they have mentioned is the use of povidone iodine in men prior to the transrectal biopsy. And this has significantly decreased the infection rates in patients who are undergoing transrectal prostate biopsy. Cleansing with an enema may not be factor responsible for decreasing the infection rate, but povidone iodine plus enema plus an antibiotic prophylaxis has significantly decreased the infection rates. When we talk about the transperineal biopsy, just single dose of cephalosporin will recommended. So we have to be very clear about the antibiotic guidelines, and there should be no confusion about it. Why? Why the EU suddenly thought of discouraging the use of levofloxacin or fluoroquinolones? The reason for it being the increasing global distribution of the fluoroquinolone resistance. So this is a very beautiful systematic review and meta-analysis which has been published in 2022 regarding the actual present prevalence of the fluoroquinolone resistance. And we can see that in the European countries, there is about 10 to 20% prevalence of the fluoroquinolone resistance. And they have discouraged the use of fluoroquinolones in these countries because of this. But if we talk about the Indian and the Asian countries, we have higher prevalence of the fluoroquinolone resistance, and this requires us to think about multiple times before we use the fluoroquinolones, because we are heading towards the fluoroquinolone resistance, and levofloxacin being a very important antitubercular drug, we have to discourage its use in other cases wherever possible. What does the EAU guidelines come up with? The first choice should be a transperineal biopsy. The main reason for shifting towards the transperineal biopsy as the first choice is the decreasing the infection rate, discouraging the use of fluoroquinolones, which is building up as a resistance in many countries. So the first choice being the transperineal biopsy. And the second choice, if it is not possible, there is no option, we have to go for a transrectal biopsy. If we are getting a transrectal biopsy done and the patient lives in a country where the fluoroquinolone is licensed, in those countries, the first choice is still the targeted prophylaxis. We don't go for a fluoroquinolone. It's fluoroquinolone is always the last option, even in countries where the fluoroquinolones are licensed. This is a very useful piece of information that we get from the EAU guidelines, and there is no second alternative to it. We have to understand the importance of this. If the patient lives in a country where there is fluoroquinolone resistant or fluoroquinolone not allowed or prohibited, in those countries, as we discussed, these following options: targeted prophylaxis, augmented prophylaxis, and alternative antibiotics. Having understood this antibiotic prophylaxis, we have to know that all this discussion is about the complications. Having discussed about this patient preparation and the antibiotic prophylaxis, let's see in the next video how do we position the patient